Have to wait for a second. We have to go on to our first speaker of this session because he needs to catch a flight. We have Dr. KRISHNA PRASAD KUDLU. He needs no introduction. Most popular and dynamic national figure in ophthalmology and member scientific committee. And the big man in Karnataka and looking at political connections. So we look forward to hearing from him on a very relevant topic, current trends in presbyopia correction, preferred practice guidelines.
Thank you, Chitra Madam, for a wonderful introduction. I think it's a pleasure to be part of ARC program, and this time Madam has really made a history to get the fantastic programs from ARC. As a scientific committee member, we are very much proud and also feel jealous that Madam has done such a wonderful program. So this is my financial disclosure. I'm consultant for Carl Zeiss India. So just for beginners, what exactly is a presbyopia? Is a physiological progressive loss of accommodation affecting individual in their middle age regardless of any underlying refractive error, causing difficulty in sharply focusing for near vision. Different principles used to correct presbyopia. Either we can do monovision, one eye for distance and other eye for near, or some of the examiner system even do a multifocality treatment. You can try the people used to try with that, or with the increased depth of focus, what we do it with the camera inlays, and even you can go for a combined approach. See, I was just a few of my friends from Colombia. They have been trying something called FOV tears. It's a mixture of parasympathetic eye drops. They say that definitely it corrects presbyopia. I don't have any experience with that. Of course, spectacles everybody been using. Even some of the international companies also come up with the multifocal contact lenses. So these are the surgical options for presbyopia. You got lens-based procedure, you got multifocal intraocular lens, trifocal, EDOF. Corneal procedure, you got presby LASIK, presbyon, and corneal inlays. And one or two word about sclerociliary complex modification. People in Europe, they are still doing scleral spacing device or laser rays procedure. So I will not talk about much about multifocal IOLs. If you got astigmatism, you can think about toric multifocal IOL. Of course, now most of the we surgeons are converted to trifocal intraocular lens because of the advantage of intermediate vision. But now EDOF lenses become more and more popular because of the great nature of very less glare and halos, and even you can implant in a very young individual. They want to try comfortably in the night and also can look at the meter board very easily. These are the couple of lenses. One is from Zeiss and this is ACRIS of IQ VVT. I think once again it's a non-diffractive EDOF lens which has got a very good distance and a reasonably good near vision too. So a lot of my friends even still doing with the non-dominant eye multifocal and dominant eye with the EDOF lens, they're still getting a good result for presbyopia. Even I think I don't have much experience. I think our friend Kamal might have done few of the phakic multifocal lens from one of the Indian company. Even I have tried couple of patients with the Sulcoplex pseudophakic lenses. So these corneal inlays has become popular much 5-6 years before. Most common one is camera inlays. Normally we put it in the non-dominant eye by making a small pocket within the stroma. But all these inlays have got a problem. Definitely there is a slight reduction in the distance vision in non-dominant eye, glare and halos, and reduced contrast sensitivity. So sclerociliary complex modification, what they make, they put a 4 PMMS segments which is implanted, make a 4 incision, and they put it within the sclera. It will have a near vision effect. Even people tried with this is something called laser rays procedure by giving a YAG laser to ablate 600 micron in the sclera, which presumed to have to free the ciliary muscle to contract normally, have a near vision effect of 1.5 diopter. So let me come to the laser options. I think presby LASIK, 10 years before, a lot of people have done. It's a multifocal LASIK treatment based induces spherical aberration. But normally they had a good near and intermediate vision. But the problem is initial compromise of the distance vision. A lot of people take up to 3 months to adopt this treatment. It is a people dependent, and also the patient complained about near vision. So coming to the supracore some of my friends in India been doing this with the help of examiner system Technolos 217 from Bosch and Lamb. Unlike monovision, which one eye is treated for distance and other eye treated for near, here each eye has to treat for both for distance and near. There is something different in supracore. So how it works, actually it makes the use of central near peripheral distance concept, wherein during the natural accommodation, when eye focus on the near object, the pupil constrict and eye looks it through the near elevation. But when eye is looking at a distance, pupil dilate, allows the peripheral rays to pass through the aspheric optimized periphery to improve the distance vision. But basically hyperopic treatment, lot of require retreatment, yet to become more and more data with that. So presbyopia I've been doing last 12 years, excellent results. Basic important is refraction, dominant eye testing. I myself being a doctor, I do. For me it takes almost 45 minutes to finish all these tests of micro monovision testing. These are the principle of laser branded vision, monovision, depth of field, neural summation, blur adaptation and neural separation. What we make dominant eye emmetropic, make the non-dominant eye myopic by 1.5 diopter. Blend zone is the zone where the vision from dominant and the non-dominant eye meets up and binocularity retains. So along with that we also create a spherical aberration in both the cornea. So why we pick this in small children, you have seen brain tend to suppress certain blur from one eye, same principle we have taken. Basically it's a bilateral treatment and this is our results. I think more what I wanted to just say, none of the eyes actually in our lost more than half a Snellen lines of vision when compared to pre-operated corrected disturbed visual acuity. So these are the advantage with presbyopia, not depend upon the pupil size. I have done up to -8 diopter even with the hypermetropic of 5 diopters. All my patients had a very good intermediate and near vision, and more than 97% of the patients adapt very well. So take home summary, I think very important, dominant eye testing has to be done very well. Age between 40 to 55 laser refractive surgery. More than 55 years age, I think you should opt for lens based procedure. Type of refractive, whether it is myopic or hypermetropic, wait for the stability of the refraction, go for laser refractive surgery. If patient in a hurry, you can still opt for lens based procedure. Of course, in aberrometry, very important, check for dysfunctional lens index. If there is no cataract, presbyopia is the option. When you see in the end compared to multifocal IOL, corneal inlay, presbymax, supracore, I think as far as the distance vision, intermediate vision, near vision, night driving problem, contrast sensitivity, adaptation, presbyopia will have a edge over all this treatment. Once again, I thank Chitra madam for this wonderful opportunity. Thank you, Ananda.
Thanks, KUDLU. Thanks a lot for sparing this morning before you catch your flight. All the best to you.
Thank you, madam.
One question to Dr. Kamal Kapoor. What would be your choice in very high myopes who want presbyopia correction as well? Just the right conservative approach I want from you for the audience.
Very high myopes, in the sense, my current choice right now is EDOF. But if the anterior chamber depth is higher, in my experience, I'm nearly to experience.
ELP becomes a challenge.
Yeah, that's when the problem actually starts happening. So in these cases, I think giving a micro monovision for these cases is a very conservative and a safe approach. And it's always a good idea to keep even the dominant eye slightly myopic by 0.5, because these patients are used to not a very, very good quality distance.
But having said that, what age group onwards would you consider doing clear lens surgery for them?
50 plus.
Yeah, that's what. So that's the message I want to the audience, that let us not get aggressive with the younger lot, because there is 8 times chances of getting retinal detachment. And actually, if you do the thorough examination, if they have already have a PVD, then it's even better. It gets even safer if you are planning it a year or two in advance.
Just one question, Dr. Kudlu sir, very nice presentation. Just wanted to ask a question. If you have operated on a patient for presbyopic correction, like say presbyon at the age of 40, now you have said you have had an experience of over 12 years. When they come back to you, say 10 years later, at that time, do you give them a near rad, or now they are resigned to the fact that they would need a near rad?
Yes. Yes. So that gives 2 diopters. Yes.
Okay.
So
Yes.
one question just add, if the patient develop cataract after 60 years, 65 years, what I do, I put a non-aspheric lens in both the eye, but for non-dominant eye, I make my 1.5 diopter less. So the effect of presbyopia still remains.
The sequence is going to change a bit about the speakers, and I want you all to clearly understand the session is preferred practice guidelines. I want 1, 2, 3, 4 points. How would you manage these cases? I do not want any introductions at all. I want to go on to the content. How would you manage? What are the challenges? What are the limitations? That's what the audience is